All right, ladies and gentlemen, coming at you once again. It's Mr. G here. We are in exercise programming for special populations, and this topic for Chapter 7 is all about immunologic and hematologic disorders. Now, much like we've done in some of the other chapters, we're only going to focus on a few of the most common ones that you might actually come into contact with, but I will mention some of the others that are not in the slides I have here, just to kind of give you an idea as to why I did not choose to include them as part of this discussion. And I think it'll make sense to you as we go along. So without any further ado, let's find out about some of these immunologic and hematologic disorders. Here we go, systemic autoimmune and hematological diseases. Now, what characterizes these diseases? Now, hallmarks of these diseases are an inappropriate immune response that results in inflammation and tissue damage. Intervention usually involves minimizing symptoms and further damage, developing effective management and coping strategies, improving functional abilities, and improving quality of life. We're not looking to reverse anything. We're not looking to change anything. In fact, you're going to see here in all the different examples that we have for this particular chapter, those aren't even things that we can do with exercise. However, as we are well aware, the benefits of exercise and physical activity are going to be pretty helpful for just about everything, though there are some exceptions. And we'll get into all of that as we go through these immunologic and hematologic disorders. So let's start with the first one that we have here, which is something that you may come into contact with. In fact, you might already know someone that has RA or rheumatoid arthritis. My mother-in-law has it. I've actually worked with some colleagues that have had it, that actually exercised with us and participated in the Tough Mudder run that we did for Kaiser back in 2014. So that was someone who did struggle with a lot of things we're going to talk about with rheumatoid arthritis, but she powered through it, championed through it. And one of the things that she said, especially as we were training, and we trained hard, was that the exercise that we were doing really made her feel better. But before we get into the things that it can do, let's define what it is, how it's treated, and then we'll figure out where our part is in all of this. It is an autoimmune disorder that results in chronic inflammation in the joints, and that's associated with long-term muscle atrophy, joint deformity, and disability from a decline in mobility. These folks are hurting all the time. Their joints are hurting, so they're not moving. Their joints actually can get deformed as a result of the pain and the inflammation that's going on, and they're not moving. Those muscles atrophy. It's a downward spiral, and it can lead to a whole slew of issues. And some of those conditions that it's linked with, they can be debilitating on their own, including lupus, coronary artery disease, and osteoporosis. Now, lupus is something that is in this chapter that we're not going to really go over a lot, but quickly I'll tell you what it is. Lupus erythematosus, as it is formally called, or just lupus, it is known as a multi-system idiopathic disease that's characterized by both acute and chronic inflammatory destruction of the skin, that's on one end of the spectrum, but also the chronic inflammatory destruction of the skin, joints, blood elements, kidneys, serosa, nervous system, and other tissues. It's pretty broad in range. For people that have it, people with lupus, autoantibodies in the bloodstream may target healthy tissues rather than fight foreign infection agents that cause defects in both humoral and cellular immune responses. So it's something that attacks the entire body, and it can range in terms of its severity depending on what type of lupus you have. On the lower end of the spectrum, at the lighter end of the spectrum, you've got something called discoid lupus erythematosus, or DLE. That primarily is going to affect the skin and not really much else. So really, if you have lupus, that's the better case scenario. Whereas if you're on the opposite end, where it's more severe with systemic lupus erythematosus, that's much more serious, and it's going to be threatening your organs. So that's something that can be linked with rheumatoid arthritis. There's exercise recommendations in your text regarding lupus, but it's not as common as rheumatoid arthritis because, as you can see in the last bullet we have here, it is the most common autoimmune disease that's out there. It affects about 1% of the population worldwide. So this is something that you can expect as an exercise professional at some point to deal with your clients coming in with RA. Now, it works like this. It first affects the synovial lining of the joints and the cartilage, but as it gets more severe, as it develops over time, that can spread to the myocardium, the lungs, kidneys, and other tissues. So now then it starts to attack organ systems, and you can imagine that that's a pretty significant progression in terms of its severity. It's classified, the severity of it is classified based on the number and size of the affected joints, presence of rheumatoid antibodies, and the duration of symptoms. So it's going to vary from person to person in terms of how severe it is. There's also no cure for it. So there's nothing you can do once you've been diagnosed with this as an autoimmune disorder. The goal of treatment in any capacity when it comes to RA is going to be to control inflammation, because inflammation is a huge part of it, and minimize pain so that these people that are living with RA, that they can maintain a good quality of life, activity, and mobility. They're in pain all the time, joints are aching, they're not wanting to get up and move, and so you can imagine that's not the most exciting existence. It's not the happiest existence that you want if you're in pain all the time. So any kind of care and treatment that's going to be provided is really going to be to help reverse that, to minimize that pain so that people can move around and do what they want to do and live a life that's worth living. And that is something that we can help with. Now, before we come into it, there are medications here. And I'm going to tell you something about medications that can apply to everything we've talked about so far and to all of the disorders that we're going to talk about, not just in this chapter, but in all the chapters that we have for this text. And that's in your books. If you go to the end of each respective chapter, not only have we seen tables that actually outline like recommendations for exercise programming, they give you an idea of how you should put some kind of program together to help someone who has the particular disorder or disease that we're talking about. But at the end of the chapter, they actually have a table where they list the common medications that are used to treat these different disorders. So how does that help you? Why am I saying that here? Well, the reason is because I've told you before that this textbook, this one here, is something that you absolutely want to keep. This is not one of those texts that you want to sell back to the bookstore or just rent for the month, because it has a ton of really high quality, conveniently placed information. I know it uses a lot of big words and sometimes it's hard to follow, but in the back of the book, or in the back of each chapter, it gives you a medications table for each of these diseases and disorders. And it'll name the type of, first of all, it gives you a drug classification like what you see here on this slide. Like if we're talking about NSAIDs or DMARDs or synthetic DMARDs, and I'll talk about those in a minute. But it gives you their drug class and names. It tells you how they work. That stuff, again, you need to know what it is, how it works. Maybe that's not something you need to know, but it tells you what the most common side effects are, so what you can expect with a patient who's actually taking this. And finally, it tells you what the effects are on exercise, even down to the fact that some of these things, for instance, I'm looking at one on lupus here. I'm looking at the table here, and there's a medication listed in the back called DHEA. It's a male hormone, and they talk about what it does, and it's used to treat lupus. But at the very last segment here, the effects on exercise, it says, it is not known to interfere with exercise capacity, response, or adaptation. So even though we're going to look that medication up and see if they're taking it, we're going to go back to a table like this, see what's there, and it says that there's no known interference with any exercise capacity. So that's not going to alter our methodology for choosing how we're going to program for this person. So again, this book has a tremendous amount of resources in it. And at the end of each chapter, you will find these medication tables that are going to be super helpful to you, not just in this course as you're going through all of these things here and putting together your own programs, but also when you're working in the field and you're working with clients who have these issues and they're taking these medications and they're listing them on their paperwork when they first come in to see you. You can go back to a table like this and know exactly what your limitations are, what are some things to avoid so that you can choose the best exercise programs for them. So I really wanted to stress that point, make sure that you keep that in mind. It'll come in handy as we go. Now, as for these medications for RA, let's spend 3 minutes talking just to get to what we're here for. NSAIDs, or those non-steroidal anti-inflammatory drugs, those are used to treat pain. Short term, no known effects on exercise except for possible attenuation of the tissue repair process. So that might slow down how fast they heal from exercise sessions, but it's used to treat pain. Disease-modifying anti-rheumatic drugs. These are a little more serious, and they're going to affect the immune system. They're synthetic chemicals that are going to be put into the body, biological response modifiers, and glucocorticoids. So they're meant to help assist with some of the issues with the rheumatic component that we talked about in one of the previous slides here. And they're slow acting. They take a long time to get there. They're given early to minimize long-term joint damage, whereas glucocorticoids last only weeks to months. So different kinds of drugs, different types of treatment. They're going to affect the immune system, so someone is more likely to get sick or have some issues along the immune system response. So there's no free rides with any of these medications. Here we go. Here's what we can do. And similar to healthy individuals, people who have RA will get tremendous benefits, including improved functional abilities. Because you can imagine if you're aching all the time and then you're not moving and you're stiff and in pain, your functional capacity is going to diminish over time. So by exercising, you can actually help to increase that functional capacity. Resistance training is really going to be beneficial here because these folks who have RA, they are prone to falls. So research indicates enhanced balance and range of motion from resistance training and neuromuscular training such as yoga and Tai Chi. So incorporating some of these mind-body exercises, things that are going to really help people to train their balance and stability is going to be helpful, especially because they're not moving quite as much, possibly because of the pain. So getting them in this program can really help them, especially with preventing falls, because you can imagine if you're already in pain, well, if you fall down, it's going to be that much more painful. Just like I mentioned about medication tables that are located at the end of the chapters, within the chapters we've got some nice little tables that talk about how we should program. Now when it comes to this, it really depends on the classification of rheumatism, but if usually because of the rheumatoid arthritis presence, your exercise is going to be low or no impact for the most part. But you should kind of change up what the mode is to avoid overuse and provide a little bit of variety while you're doing it. Intensity should stay pretty low to moderate in terms of your heart rate when it comes to aerobic exercise, 2 to 5 days a week, preferably every day. Again, the idea here is to improve that functional capacity and keep people moving. So even though we usually, stick closer to those 150 minutes a week, 5 days a week, think about this. The fact that someone's joints are hurting and they don't want to move, and the less they move, the worse their symptoms are going to get. Maybe it is a better thing to have them doing something every single day. Resistance training sounds very much like what we would do for our general population. Had 2 to 3 days a week, 1 or 2 sets, 10 to 15 repetitions, progressed up to 3 to 4 sets over time, and of course avoid any ballistic, explosive, plyometric movements. Again, non-impact, because impact really affects the joints. We're talking the ankles, the knees, the hips. They're also going to have a lot of issues in their hands and in their finger joints. This is going to be some of the big primary problems that folks with RA have, so you want to be sensitive to that in your programming choices. Modify those exercises, choose what works best based on the joints that they have that are most affected by exercise. You're looking to encourage pain-free range of motion. That's what you should be looking for. And then a cool down, at least 5 to 10 minutes, low intensity exercise or static stretching is recommended once they are done. So don't neglect the cool down. I know we always kind of talk about how most personal training is set up today. People are paying for a shorter amount of time, so we don't necessarily sit and do a cool down with them, or we don't sit and do a warm up with them. We might give them some homework to do immediately before, immediately after, Whatever your methodology is, and however much time you might have to work with someone, just make sure that you do include these components and really stress their importance, because they're going to make a difference in terms of how someone is going to benefit if they have RA. The next one we're going to talk about here is chronic fatigue syndrome, which is interesting, and you'll see why as we talk about it. It is an autoimmune disease that is characterized by unexplained fatigue lasting more than 6 months and not relieved by bed rest. As I'm learning about this stuff along with you guys and talking more about things like chronic fatigue syndrome, even as I get into the science of it here and talk more about it, you might find yourself, you're someone that's kind of like me, and maybe you're just tired all the time because you're working or whatever it is you're doing. I don't know that that's quite enough to be considered chronic fatigue syndrome, and so we'll look into it here and see where you fall in terms of what your thoughts are on this. It is diagnosed more often in women than in men. 83% of all cases belong to women more than men, and occurs usually between the ages of 20 and 50. So to me, I find that interesting because I think of those as childbearing years. And I know, since I've had children and I'm in that age range, and my wife too, she's exhausted all the time. That might have something to do with it, but this is something that is thought to be more autoimmune in nature. So we'll look at some of the other associated symptoms that go with it, and this is maybe where the difference is between just being generally tired all the time and having this chronic fatigue syndrome. Remember, this is going to get diagnosed by a doctor. They'll ultimately be in charge of determining whether you have something like this. But here's the symptoms. Sore throat, headaches, possibly some sleep disturbances, maybe some insomnia, depression, and it's also often found in conjunction with other disorders like irritable bowel syndrome and fibromyalgia. And fibromyalgia is something that we will talk about shortly once we're done talking about CFS. What causes this chronic fatigue syndrome? We don't know. It's unclear. Diagnosis is usually based on self-reported symptoms to a doctor and exclusions of other possible diagnoses. So they're going to look to make sure that you are not suffering from something else, because that could be the issue, not necessarily this chronic fatigue syndrome. But nonetheless, it has developed its own classification criteria, its own diagnostic criteria. So a doctor will diagnose it based on the kinds of symptoms that are reported by the individual who is having them. Treatment of this particular syndrome focus on management of the symptoms, and also with pharmacological intervention, stress management, counseling, proper nutrition, nutritional supplementation, educational interviews, group therapy, energy conservation, and regular physical activity. If you're tired all the time, if you're chronically fatigued and exhausted, it could be a result of many, many things. Again, it's unclear as to why it happens, but we know from our studies the importance of nutrition, the importance of physical activity, the importance of good sleep, the importance of maintaining a good quality of life by minimizing the amount of stress or changing the way you feel about supposedly stressful situations. This could be the case where this is general lifestyle management that we're looking at here with treatment. And that is something that we as exercise professionals can assist with. Medications. Now we said pharmacological interventions, maybe for something like antidepressants, but there's no really scientifically backed medications designed to really target CFS specifically. They are individualized really to the symptoms. So whatever your strongest symptoms are, that's going to be what doctors look to treat. Things like sleep medications to help with insomnia or sleep disturbances, if you have pain, if you're depressed, those are going to be the kinds of medications prescribed. And again, you can look those up and see where they fall and how they affect exercise. Stimulants, if they give them any stimulants, a little pick-me-up, if you will, those have been shown to benefit exercise performance. They do help to delay or dull the sensation of feeling fatigue, but they may also decrease the ability of the heart to appropriately match the heart rate to metabolic demands. Stimulants are going to have an increase in terms of your heart rate and heart activity, and if your heart is not matched up appropriately with what you're doing, that's something known as chronotropic incompetence, when that heart rate doesn't match the metabolic demands of what you're doing to it. So how can we help? Well, the effects of exercise. Now, keep in mind, now the key thing here is fatigue and maybe a sense of general discomfort or malaise, as we're saying here. Exercise intolerance is common for folks who have CFS, and post-exertional fatigue or that general discomfort can be quite severe. So what might happen with them now adding exercise into their life is that they might begin to find excuses and engage in avoidance behaviors. Even moderate activity and activities of daily living are sometimes difficult for people that have chronic fatigue syndrome. Now we know that there are physical benefits. Resistance training can improve strength and lead to lower fatigue. Reaching volitional fatigue, however, should be avoided as it can exacerbate symptoms. So you don't want to push anybody over or do too much. Yoga and other exercise modes may also reduce sleep disturbances and CFS symptoms. So that might be a better way to go. To stick more towards mind-body, things that are really not overwhelmingly taxing on the body, too vigorous, because even moderate activity can be problematic. Really, when it comes down to it, if somebody comes to you with chronic fatigue syndrome, you just have to treat their symptoms. Start with things that they know, that they're familiar with, that they can do, and that are well tolerated, that aren't going to cause them undue stress and tire them out too much. Light activity on most or all days of the week, and exercise that's going to help to improve functional capacity without overdoing it. That's the big thing here, is we really need to focus on not doing too much, because you could send them packing, send them running in the other direction, and possibly even worsen their symptoms when it comes to fatigue. We want to help them and make them better. Aerobic exercise should progress first in duration and frequency before intensity. So don't necessarily increase how hard they're working for aerobic exercise. Get them to do it longer. Get them to do it more often. This progression process should take longer than it would for healthy clients, because you have to be very, very, very delicate. Shorter bouts might be more effective at preventing excessive fatigue and improving compliance. So again, start with that very short bout and then look to increase the duration before you go up with intensity. Symptoms are going to dictate all of it. Tread lightly. Now, if you start to see that their symptoms worsen, or you're getting a sign that maybe it's too much, you got to back it off. So those symptoms will dictate how you need to focus on intensity, duration on certain days. But there are going to be other days where maybe you have fewer symptoms and you can go a little bit more, but don't get too crazy. I know that's kind of our natural inclination. Hey, if you're feeling good, let's do more. Well, you got to be careful with that, because if you do overwork them and all it takes is one little time to do it or one wrong move, and you can bring on very severe post-exertional fatigue. And if they're super fatigued after exercise, and it might be not even while you're there with them, maybe they had a great workout, but they're just blasted when they're done, you could really send them spiraling in that opposite direction. You want to have a good amount of rest between sessions. That's crucial to avoid excessive fatigue and promote compliance. So maybe less so than even what you would do for your regular healthy clients. Maybe every other day is usually what you might do, but maybe waiting 2 days, maybe 3 days. Again, over time, we look to increase the frequency. For now, early on, just get them doing something. Get them doing it infrequently, enough so that you're not shocking the system too much. For flexibility, dynamic and static stretching, just like for everybody else. Daily trunk stability exercises first, and then progressing more distally. So that's where we'd go out to the arms, legs, etc., hands, feet. Start, though, at the core of the body. Use body weight exercises, because that should be, again, functional. Add resistance once they can do 10 to 15 reps with good form and without significant fatigue. A lot of factors to pay attention to there. The intensity should allow clients to feel as if they can perform more reps at the end of the set. And again, that will avoid that volitional fatigue, because we don't want to get to that point. One set of each exercise should be good enough for those initial gains, those initial improvements we're looking for. Again, this syndrome, CFS, be very, very careful, tread lightly, and don't do too much because they are going to be too tired. They're going to go the other direction. Now we talk fibromyalgia. Symptoms of this are going to be similar to CFS, but it will also include widespread musculoskeletal pain, sensitivity to palpation. So if they press on certain areas of the body, they're going to be more sensitive to it, possibly more painful, and fatigue, just like we saw with CFS. Up to 70% of individuals who have fibromyalgia also have CFS. So that's where you might see it in conjunction with something else. This is also primarily women, but this is dependent on the classification criteria. There's other studies that show sometimes men are more in a certain age range. Symptoms are more severe in younger and middle-aged adults compared to older adults. It really all depends, but primarily we're seeing this in more women than men. Other symptoms that go along with fibromyalgia: general stiffness in the body. They go to sleep, but they don't feel refreshed or restored afterwards. Headaches, light sensitivity, maybe even cognitive impairment, so not the ability to think or work actively using their brains to solve problems. The diagnosis of this disease really is also, just like we saw in CFS, is largely dependent on those self-reported symptoms, but they're looking into 3 criteria areas in order to determine this. One is pain and symptoms experienced in the past week, including tenderness at 11 out of 18 anatomical sites. So they test 18 different sites on the body to see if there's tenderness there, and if they get to 11, that's one of the diagnostic criteria. Symptoms that last at least 3 months at the same severity, the same level, and then no other health problems that could explain the symptoms. Again, this is one that is based on symptoms and based on what is self-reported. So getting to the bottom of it to make sure that you get an accurate, helpful diagnosis is really an important component here before you can really send somebody out with this diagnosis. At least good doctors will go through that process. If you're wondering what causes it, truth is we don't really know. They propose multiple possible triggers, but it's not really anything that they've come to any consensus on. Individuals that have it have been shown to have a higher level of substance P, which is a pain regulator, pain sensation regulator. No known cure for it. Goal here, just like we saw before, symptom management. Things that we might put in are not just limited just to exercise or medicine. Looking at maybe group therapy, getting them involved socially, massage, joint manipulation, myofascial release, therapeutic exercise. Meds, again, the goal here is pain relief because there is some general pain throughout the body. If their sleep is no good, we want to try and help with that. And then improvements in mental health. And sometimes in mental health capacity, what also might be piled on with fibromyalgia is depression, like we saw with CFS. And it does happen. They do happen very comorbidly with one another. And anxiety is another one. So you're going to get medications possibly to treat those issues. Specifically, you probably heard of some of these before: Lyrica, Cymbalta, and Savella. Those are at least the designer brand names of them. They've got some of the more chemical names listed here. Again, just like I mentioned earlier, if someone is listing these medications and you want to know what they do and how they are going to impact you doing your job, you make sure that you go into these tables, look at them, and see what they do. NSAIDs, just like we saw, really for anything with pain, they're going to use NSAIDs. And antidepressant and muscle relaxants may have side effects that make exercise uncomfortable, but sleep aids, if they're taking those might not necessarily get in the way of us doing our job. Pain severity, symptom severity. That's what we're looking to aim our program design at. Intensity and volume, just like with CFS, especially because they happen together, really, really low. We want to make sure that we get some results, that we help them, but we do not want to make anything worse. We want to help to improve issues associated with balance. We're seeing that a lot in this chapter in these different immunological and hematologic disorders. Stretching, resistance training, and alternative activities, including mindfulness and meditation. So some of the stuff we learned about in stress management, or if you haven't had stress management, things that you will learn about in that course, those are going to be good tools to include as part of an exercise program here. You'll notice that with this particular disorder, just like we saw with CFS, the table, the recommendations, they're not quite as neat and tidy as they were for a lot of the other disorders we're talking about. Usually we're able to kind of give very specific recommendation in terms of the amount of volume of exercise, looking at specific percentages of intensity and the recommended amount of days per week. You'll see here that it's really a lot lighter. It's much more ginger in its approach. Again, you don't want to exacerbate symptoms. You don't want to send someone away and make it so that we can't help them. You have to be very, very careful. Exercise prescribed really to treat the severity of symptoms. Stick with low impact, very low to moderate intensity at most, and start off again with those short bouts and make them longer as time goes on before you make anything harder. Again, get them in the good lifestyle habits. That's what this is all about, is getting these folks to do it more, to do it better, to make it part of their life so that it's something that can actually help to improve their quality of life over the long term. Here you see, very similar to what we saw before. Body weight, before you add any resistance. Same as, you don't need to hear me kind of go over it once again. You can scroll back a couple minutes to chronic fatigue syndrome and see what's there. Very, very slow, very ginger. Go very slow for these particular disorders that we've discussed here so far. Sickle cell disease. This is one I mentioned earlier that most things exercise can help with. Well, you're going to see here that it might even be a contraindication depending on the severity of sickle cell. Sickle cell disease is a genetic disease. It results from a mutation of hemoglobin, thereby changing the shape of the red blood cells. So instead of circular, it actually takes on the shape of a sickle, if you're familiar with that. It's right around Halloween time when this is getting recorded. So you're probably familiar with the Grim Reaper and that tool that he has that he carries around with him, the long stick with that blade up at the end. That's a sickle, and that's the shape that we're talking about that these blood cells take on, the red blood cells. What that does, by having that awkward shape instead of the normal round shape that they are typically going to be in, it can actually interfere with blood circulation. It's more susceptible to damaging parts of the body and the circulatory system, and that's problematic. Now, sickle cell trait has only one mutated gene and is therefore not quite as severe as someone that has sickle cell anemia, where they've got two abnormal hemoglobin genes. If we're looking at demographics, who does this affect? It is predominantly something that affects individuals of African descent, and it is least common in Caucasians. So if you're looking at it from that standpoint, it is much more of an issue with those of African descent. However, the World Health Organization has recognized this as a global health issue. It is widespread enough that it is something to be aware of, which is why we're talking about it here today. Now, because of the cardiovascular complication risk during competition, because again, having these blood cells that might potentially clog up or cause damage or pain or significant issues, which we'll talk about here, the NCAA requires testing for it, making sure that their athletes don't have it, especially operating at that elite level. If there's something wrong from a cardiovascular standpoint, that's a significant risk that they're not necessarily willing to take. Deoxygenated blood cells take on that elongated and fragile shape, that sickle shape, and that inhibits blood flow and making blood cell damage loss more likely, especially during exercise. During crises associated with decreased tissue blood flow, so what happens if we run into this situation? Well, the individual that has this will experience pain, vascular occlusion, and arterial and venous thromboembolism, and which can cause organ damage, and that can result in a shorter lifespan. So this can be something that is life-threatening. And you can see exercise is something that actually really, it might be contraindicated depending on how severe their issues are. And that's the thing here. If it is mild to severe, that's what you need to know. It depends on the individual. It can affect the spleen, kidneys, liver, bones, joints, eyes. I mean, it's affecting a lot of different complicated system and components of the body. In addition to the organ and tissue damage that we've mentioned, it can also result in low cognitive function. It can affect attention span, sleep disorders, because there's not enough oxygen getting to all of the area, to the brain. It is a dangerous, bad thing to have. And it's something that it's not caused by anything. It is a mutation in cells. It is typically passed down. That's why it falls into this chapter here. There's nothing that we can really do about it, and it needs to be diagnosed by a doctor. Lots of pain medication here. Some pretty significant side effects: nausea, vomiting, constipation. It might affect the functioning of the spleen, and that can affect their susceptibility to infection. Maybe they're given penicillin, which is an antibiotic, to prescribe to on a preventative basis, just so they don't get infections. Blood transfusions, stem cell transplantations are also used, and the latter of which is the only cure for sickle cell disease. So there is a cure in the sense that someone can get maybe stem cells transplanted. That's probably worth a little bit more research, something that is probably not cheap, probably not all that common to have done, and possibly not every single person is going to be eligible for that. If someone has sickle cell anemia, their threshold, their capacity, their VO2 max, it's all going to be a lot lower. And so there's increased risk of lung and cardiac dysfunction. So their system of just moving oxygen through the body, through the bloodstream, is going to be impaired. Impaired heart rate recovery, that's all secondary, but a lot of issues there. Exertional sickling and rhabdomyolysis is a major health hazard and often deadly in athletes. Rhabdomyolysis, for those of you that have taken some injury prevention classes before, just think of the fact that once you exercise, especially if you exercise intensely, you'll have that DOMS, right? DOMS stands for delayed onset muscle soreness. It's something that happens when we go a little too hard and you tear a few too many fibers and you're sore for a couple of days. Usually 2 to 3 days after is considered the normal amount of time to experience that muscle soreness. However, if you do so much damage, if you stress those muscles too much, what can happen is that can result in something called rhabdomyolysis, where the pain is actually more severe. You actually start leaking other chemicals into the body that can poison the body. It requires usually hospitalization. Some of your former classmates, I'm not going to name any names, but one of my students who was in an injury class with me a year ago, maybe a year or so, we were talking about rhabdomyolysis, and then over the weekend, because he was someone that engaged in fight sports and coaching there, he actually, in doing some sparring with somebody, actually had rhabdomyolysis because he was stressing his muscles so much that he caused it. This is a more significant risk for someone with sickle cell anemia, and it can be deadly. Moderate exercise can be safe. It has been shown to be safe, but we don't know how much is considered moderate or intensity that's safe and effective. So the doctor's clearance and recommendations that come from a more advanced medical professional, that's going to be crucial before we start working with somebody who falls into this classification. Because there is no real research on it, and because we can't really figure out, because it's different from person to person, there is no specific recommendation for those with sickle cell anemia. But generally speaking, a good rule of thumb perhaps is 20 minutes. Don't go more than that, because you could potentially be doing a bit too much, and that can have, like we saw, some potential life-threatening consequences. In order to avoid that, make sure that any exercise that's done with someone that comes in your door that has this is very low intensity at first. Figure out what the intensity works at to see how much they can tolerate, and then from there prescribe what they should do based on their individual responses. If they've got an enlarged spleen, if that's part of their deal, they really should not participate in any contact sports. That's something good for us to know. but a doctor's probably going to tell them that. Some athletes do have this, so that's where this comes in. This one all comes down, ladies and gentlemen, to what the doctor says. If it is severe, you have to be very careful, and possibly you can't do very much at all, because as you can see, it can be devastating, the effects. So exercise can really have an effect. If it's more minor, then we can look at some of the things we saw here and really look at what that doctor's clearance said and work off of that, and of course be very, very sensitive and watchful over the symptoms that our clients would have. Folks, those are the only ones we're really going over here. Now, reason being, there's some other things in here. I mentioned lupus. There's HIV and AIDS is also included in this chapter. A few other autoimmune and hematologic disorders. Hemophilia is in here. And the reason we're not talking about those quite so much is because, just like what we've seen here, the recommendations for those folks are going to be a little bit closer to general population. So the same kinds of exercise recommendations and guidelines that we would use for most anybody are going to be applicable to folks with, say, hemophilia or possibly diagnosed with HIV and AIDS. With those, similar to with anything that we've talked about, it really all comes down to how severe their disease or disorder is. What symptoms do they have? How progressed and advanced is it? So in the case of HIV/AIDS, as time goes on, as that disease worsens, the symptoms are more pronounced, and so there's going to be more limitations. But for someone that is living relatively healthy with HIV and they don't have any significant limitations and their medications aren't necessarily going to interfere, you're going to train them like you would anybody else. Of course, being sensitive to things that might leave them open to any bloodborne pathogens, but even that's something that you should be cautious of with any potential client that you have. So the other ones that we didn't talk about here, you are responsible for them just like you would be for anything that's in here. We want you to know about all there is to know, but the ones mentioned, the ones that we've gone over here, they are a little different. They are common enough that you might encounter them, especially sickle cell and rheumatoid arthritis, perhaps even fibromyalgia. So I want you to take away some lessons there to learn some new things about them. Know that these other disorders and diseases are lumped in here with them, and know that you do have a great resource in this textbook that can actually help you if you do meet someone and you're like, I don't remember going over that. Well, in here it'll tell you a little bit about it, and it'll give you the same kinds of recommendations, including the recommendations for programming and what to do based on what medications they have. That's all I got for you for Chapter 7, folks. Hope you learned a lot, take a lot from it, and we'll see you on the next one, Chapter number 8, when we get to that point. Thanks, folks.